Good morning, everybody. Thank you so much for joining us. So if you, a large part of this day, by the way, is going to be centered around group discussion. So if you want to go ahead and sit at common tables and meet some new friends, please feel free to do that. Yeah. So welcome. Thank you for coming out on a Sunday morning to talk about clinical ethics. We're excited to welcome you to our clinical ethics pre-conference workshop, and also hopefully you'll be staying along for our conference for the next couple of days. If you're from out of town, welcome to Loma Linda. It's a perfect Southern California day. Oh, thank you. Well, thank you so much. I'm really glad I'm not in charge of the tech stuff because we probably wouldn't get off the ground. Just a couple of things about today's program. If you do want paper handouts, those are out at the table. If you are okay with looking up stuff on your tablet or on your computer, if you just scan the QR code of the signs available to you, then you will actually be directed to a Google Dropbox. A Google Drive. And on that Google Drive, you'll find not only the presentations and the case studies that we're going to have, but also all of the citing articles too, and some additional articles that as we were creating these lectures that we thought were helpful. So please feel free to take advantage of that. If you would like some CME credit, then I want to point out how to do this. If you scan this QR code here, it will direct you to log in, and then at the end of the day, we'll give you about 10 or 15 minutes to fill out the evaluation form. And then after you log in and fill out the evaluation form, your CME credit certificate will be downloaded to you and instantly available. So it's a pretty easy system. I've used it a couple times and actually just on Friday, and it was actually very easy from a user standpoint. If you do have questions, then you can email our CME office at cme@llu.edu. And the QR code is going to be active till 10 o'clock tomorrow morning. After that time, if you do want to claim credit, then you would have to actually contact the CME office and ask them to reopen the QR code for you to fill in the evaluation. So anyway, well, at the end of our day or time here together, we'll go ahead and give you some time in order to do that. So any questions about that? Awesome. All right. Well, today we do have a pretty packed day for you. We're going to be spending the first hour or so analyzing what I call the ethics, the fundamentals of ethics consultation. And I had a privilege of meeting a few of you prior to the start of this. And one question was, is this for bioethicists with graduate degrees? No, it's not. We recognize that bioethics and clinical ethics is a field that, in my opinion, should be open to clinicians of all backgrounds. So we want to encourage you to, if you don't have specific training in ethics, actually, this is exactly the type of conference that we've designed. You're the type of person we've designed this conference for. So after analyzing the fundamentals of ethics consultations, we're going to do another presentation on potentially inappropriate therapy. Then we'll take a break for lunch, and our lunch is going to be laid out on the tables behind us. And then we will then come back into group discussion with guided case discussion. We have a number of active clinical ethics consultants who will sit with you to guide the discussion. You can, over that period of time, go through as many cases as you can, or if you want to go in depth into one case, you can also do that. At the end of that time, we'll share some insights that we took away from the case discussions. We'll have a short break, and then we'll go into our second topic, which is artificial nutrition and hydration, and guidelines for withdrawal or withholding artificial nutrition hydration. So without further ado, let's go ahead and start with analyzing the fundamentals of ethics consultations. So our objectives to identify the stakeholders of clinical ethics consultation, what to do when conflicts of interest emerge, and more importantly, how to recognize it, and then also to propose solutions to reduce bias during ethics consultation discussions. So I thought it was really important to actually start with defining or identifying the stakeholders of an ethics consultation, so that we know when we do this ethics consultation who we're supposed to be doing this for. And then the more I thought about it, I thought, well, before we can define who the stakeholders of clinical ethics consultations are, maybe we should start with some definitions. And so a question that I get a lot is, what exactly is clinical ethics? And what exactly is it that you do? It's a subset of bioethics, yes. And the way that clinical ethics has developed, it's also very closely integrated with other subdisciplines of bioethics, such as organizational ethics and community ethics. So if we define bioethics as the discernment of values, and then we take it into the clinical realm, well, then clinical ethics is the discernment of values that guide clinical decisions that affect patient care. And organizational ethics, these are the values that guide decisions that guide managerial decisions that affect patient care. And then community ethics, right? This is the discernment of values that guide societal decisions that can actually end up affecting patient care. You know, there's really no practical way to extract the individual clinical situation from the values that guide organizational decisions and the values that guide societal decisions. And we've really clearly seen this, right, in what has been happening in hospitals in Texas. So after the Supreme Court decision in June on Roe v. Wade, a number of states passed laws restricting abortion. And so societal decisions regarding abortion ended up affecting organizational decisions and how these patients will be cared for. And that is ending up affecting individual patients and the clinical decisions that are affecting individual patients. So again, very intertwined. We talk about clinical ethics, but clinical ethics, again, is properly situated within the organization, and that is properly situated then within the society. So I actually really like this shot of the iceberg, right? And the iceberg, the tip of what you see is clinical ethics. But what gets brought up to the surface, the questions that as a clinical ethicist that we are asked, is in large part formed by what is down below, and that is the organizational aspect of the care that the patient is receiving. The bulk of the iceberg, what is below the water, right? That is very largely influenced by what is going on in the community. Again, it's hard to extract just one from the other. It's easy to see clinical ethics, but just realizing that it is, again, situated within the hospital or the system, and also situated within the society is really important. So then what is consultation? We've just spent a little bit defining clinical ethics. What is consultation? Well, consultation is the process of identifying, analyzing, and resolving ethical issues that arise in the care of individual patients. This is a really old definition. It's from Mark Siegler, Dr. Siegler. He actually published this definition in the very first issue of the Journal of Clinical Ethics all the way in 1990. And so I think it's still a good definition. So process of identifying, analyzing, and resolving ethical issues. Well, then if that's our definition of clinical ethics and clinical ethics consultations, then who are the stakeholders of our clinical ethics consultations? Well, for sure, the patient, right? and the family, but also the hospital system is a stakeholder in a clinical ethics consult. And a community, the community at large, is also a stakeholder in that clinical ethics consultation. Little less directly, but still a stakeholder. And one of the reasons why I think it's important to recognize this is because often it can be easy to say at the bedside, we don't do X at the bedside. We don't ration at the bedside. We don't do certain decisions at our system level at the bedside. And I do think there is some truth to that, a lot of truth to that. But I also think it would be short-sighted for us not to acknowledge the other influences that surround the patient and you at the bedside. So then, if we have defined clinical ethics and we now have a process, who should actually do it? So this question has dogged our discipline since its inception. Since clinical ethics started, it's been a discipline that's been open to people of a variety of backgrounds. And if you think about the process, right, we want people to be able to, or ethics consultants, to identify, analyze, and resolve. Okay, so does that mean that you should have a clinical background? And if you do have a clinical background, should you be a nurse or a physician? There were a number of people that had very strong opinions that thought only physicians could do this type of work. I do not hold that opinion, but there were those who thought that. Well, what about law? Lawyers get a specific type of training, definitely in analyzing and identifying. Wouldn't it be best if clinical ethicists were lawyers? Or what about trained in philosophy and moral theory? Or what about theologians? Wouldn't theologians actually be the best, especially if we were working in a faith-affiliated health system? Wouldn't that be the best background in order to do clinical ethics? And then the second question is, well, what kind of training should you have in order to do clinical ethics? Well, again, long-standing questions. And so in 1999 to 2000, Ellen Fox and colleagues conducted a survey to actually figure out who was doing clinical ethics consultations and what it consisted of. So very quickly, I'm going to throw out some brief numbers from that old survey, and then she redid the survey, and then we'll look at a little bit more time on the new survey. So in 1999-2000, the most commonly recorded number of ethics consults of the US hospitals who had an ethics consult mechanism was, I'm going to actually ask you guys for a guess. What do you think was the most common number of ethics consults in US hospitals that actually had an ethics consult mechanism? 0. Okay. I'm sorry, 0, 2, 5. You were not going to be surprised. I was actually really surprised when I first read that. It was 3. So, that doesn't seem like a whole lot, and maybe that rings true to your experience at where you're at. They also asked what kind of training clinical ethics consultants had. 5% of ethics consultants had completed a fellowship or had graduate degree in bioethics. And so this was actually quite startling to the ethics community and when this survey came out. And so the American Society for Bioethics and Humanities launched a certification program in response to this, and also published competencies of what an ethics consultant should know. So after these competencies were agreed upon, widely published, this actually allowed universities to create specific programs for healthcare consultation. So now, instead of having somebody who has a primary background in somewhere else like theology or law, or they're a clinician and they come into ethics, now you had somebody who is going through undergraduate and a graduate degree in healthcare ethics, and then going out and practicing as a healthcare clinician. Well, now this actually caused a lot of grumbling. But to be fair, if you only have 5% of your ethics consultants actually having graduate training, it's hard to grumble at people who are actually doing specific work in healthcare ethics. So then fast forward, let's almost 20 years later, in 2018, Ellen Fox and colleagues repeated a very similar survey, and they published their finding in the American Journal of Bioethics in 2022. What they did was they randomly sampled in a representative manner 600 hospitals, which was about 13% of US general hospitals. And I say in a representative manner, but that's actually a little bit misleading. They actually oversampled larger academic centers, but they were pretty upfront in their methodology. So out of the hospitals that surveyed, 86% of these hospitals had an ethics consultation service. Good. Of these hospitals with an ethics consultation service, 14% performed no consultations in the past year. And remember, you guys are saying, what was the median of the most common number of ethics consultations? And somebody said 0 and 5. And then we said, actually, 3 was the most common number. That number did not change. So in 20 years, the most common number of ethics consultations remained the same. Only 2% of hospitals performed between 100 to 200 consultations in the past year. And that is a category that Loma Linda would have fit into. But again, the median number of clinical ethics consultations performed was still 3. All right. So if almost 50%, one other statistics I forgot to mention was that 48% of hospitals performed between 1 to 5 ethics consults. So again, the median number was 3, with 48% of hospitals reporting that they perform between 1 to 5. So if you are in one of the almost 50% of hospitals that performs between 1 to 5 clinical ethics consultations, what kind of feedback does that give to those who are writing and implementing hospital policy, right? If your hospital only performs, or if your system only performs 3 a year, how likely is it that a community member or a patient who comes in is actually able to access this kind of service? So every hospital administrator that I've spoken with, they always say, oh, clinical ethics is so important. And I truly believe them, right? And I truly believe that they believe that clinical ethics is really important. But yet I've also been told privately by the same people that, well, we have an ethics consultation mechanism because it's mandated by joint commissions. And then I have one specific administrator who told me, oh, I think what you're doing is really important, but I personally have never seen an ethical dilemma, and I think the doctors solve them. Don't they? Well, do they? Going back to who should do clinical ethics, does it involve specialized training? Should it be from a person from a specific discipline? I do think it is very worthwhile to set up curriculums. In fact, we're setting this up as a curriculum for training for clinical ethics consultations. I think training programs and allowing people from a wide range of backgrounds to participate is key in our field. But I don't think we should be focusing just on what discipline and what training. I actually think we should be asking the question of what meta-ethic. So, for example, I think we need meta-ethics to help us answer questions like, when does withdrawal of life-sustaining treatment cross from being a medical decision to being an ethical decision? Or simply, in the course of medical decision-making, what actually is a medical decision? What is an ethical decision? We think of a medical decision as, can we do this? And an ethical decision of, should we do this? Are certain decisions, can we do this, and very little should? Are there decisions that are a lot of should we do this and very little can? I would say that the vast majority of medical decisions have some of can and should embedded into it. And so when you are in this gray area of there's some can, there's some should, when does it travel, or when does it become an ethical decision, more of an ethical decision and less of a medical decision? Another big question, how does uncertainty change a decision? How does it affect a decision from being ethically right to actually being ethically wrong? Now, ethicists, we don't like to say right or wrong. We like to say permissible, impermissible. So let me rephrase. How does uncertainty influence or change a decision from being ethically permissible to being ethically impermissible? Going back to these big questions, so does that mean that if you can't answer these questions that you shouldn't be doing clinical ethics? It seems that clinical ethics is very experiential, right? And so what in the experiential training actually trains us to be able to answer these questions? Should we only allow those with moral expertise then to become clinical ethics consultants? And talking about moral expertise, we're talking about meta ethic and what actually guides normative decisions. If you have clinical ethicists who don't have moral expertise, how much credibility does that lend their recommendation? And then finally, what meta ethic does Adventist-affiliated healthcare subscribe to? Is there something tangibly different that influences Adventist-affiliated healthcare and health system policy guidelines? If this sounds like a lot of mission talk, well, it is. I agree. But you know what? I think if we remember the iceberg, it's all very related together. So in this vein, I'm going to actually add one last stakeholder to our list, and that is the practice of medicine itself as being a stakeholder in ethics consultation. And by this, I mean that medicine is a moral undertaking. How many of you have heard this phrase? Medicine is a moral enterprise. Yeah. Commonly attributed to Dr. Pellegrino. I honestly searched for like an exact quote. I'm a big fan of Dr. Pellegrino. I have a big book of his collected writings, and I was not able to find it, but it is commonly attributed to him. So medicine as a moral undertaking, in our clinical ethics consultations, we are actually holding out as true that medicine is a moral enterprise. I mean, we deal in ethics, right, wrong, permissible, impermissible. But if medicine is a moral enterprise, what moral system should medicine be beholden to? Medicine is about as pluralistic as we can imagine, both in practice and by practitioner. So which moral theory can actually hold sway? I'm not a philosopher, and I know that I'm veering dangerously close to the limits of my knowledge, but from my training, my experience, my practice of clinical ethics, I have personally latched onto and discarded multiple moral theories, from principalism to utilitarianism. That was brief. And now I'm actually leaning a little bit away from virtue ethics to something that is a little bit more of a mix of many things. I'm not going to turn this into a therapy session, but it gives me a lot of anxiety to think that the ethical state of my personal practice of medicine is dependent on my being a good person. That's probably the biggest issue I have with virtue ethics, right? Wow. So I try to be a good person. I intend to be a good person, but I'm not that good of a person. I mean, if you heard my internal monologue, and sometimes I say the quiet things out loud, and then I hear, oh, yeah, I'm not that good of a person. So if medicine is a moral enterprise and I practice medicine and also clinical ethics, and I'm not that good of a person, what good is my clinical ethics consultation despite my training, my advanced degree, my certification, and also my experience? Am I a total fraud? Am I trying to bring you along in some sort of fraudulent enterprise? I really hope not. I guess my point is that there has to be something that holds this all together. There has to be something that holds the principles, the actions of the virtuous clinician, the ethical imperatives of various religious traditions to give the clinical ethics, this practice, moral authority, right? Otherwise, in the best of times, I'm just another voice confusing the picture. In the worst of times, I'm actually harming a patient. So I'm not claiming to have all the answers, but I do think that I have more of a concrete answer that I want to share with you than I did a few years ago. I do believe that medicine is a moral enterprise, and borrowing heavily from Dr. Pellegrino, the moral heart of medicine, which again provides the practice of clinical ethics consultation, its moral voice, and dare I say, authority. It lies within the patient-physician relationship. So instead of now asking who should do it and like what background, what training, maybe we should actually start with what metaethic. I would have to say there is not agreement on this, right? If you read some clinical ethics literature, there are those who say, well, you can practice clinical ethics without a guiding metaethic, or you can have a guiding metaethic. I mean, there's again, I get those some of the conflicting theories. I sort of get them confused because I disagree with them, and I believe that the guiding metaethic is found in the relationship that the patient has with their clinician. Now, if that clinician is not a physician, that's fine. It's the relationship that patient has with their clinician, also with their institution, and then also with the system. So within this relationship, right, we have a patient who desires something, healing, maintenance of health. And then we also have a clinician, an institution, or a system that professes to have the ability to provide the patient with what they need with competency and also sensitivity to the patient's specific particularity. So we're pledging to further the patient's good. I mean, that is as moral of an enterprise as it gets. How else can we know this good than by deepening the relationship with the patient? So I wanted to put it to you that we fulfill our duty to the patient by committing to understand the patient's experience and taking together the experience of a population of patients and families. Once we have a metaethic, let's turn now to the discipline. I actually don't think their discipline matters that much as your ability to form a relationship with the patient or the family. So if you went straight through from undergrad to now you have a PhD in healthcare ethics and you're 26 years old and you're landing in a hospital and you're doing clinical ethics, welcome to the fold. That's fantastic. What is your ability to form a relationship with your patient? Often, unfortunately, the depth of this relationship is defined by institutional guidelines and policies. So if you have one clinical ethicist to 1,500 beds or 3 different hospitals, you're going to have a different relationship with the patients requesting ethics consultations than if you, for example, had a little bit more time. Sometimes the depth of your relationship is going to be dependent or even through the medical team. Say, the patient doesn't want to talk to you as an ethics consultant. I've certainly had that. That's, again, going to limit the relationship that you're able to develop. So I believe that those involved in healthcare can come from any discipline, right? Lawyers, philosophers, chaplains, social workers, nurses, case managers, therapists, psychologists. I mean, the list goes on and on. What is really required is your willingness and commitment to enter into this relationship with your full self, to walk the journey along with the patient, to see their suffering without averting your eyes, to feel the patient's keening in your heart, to hear the anxiety in your patient's voice that is brought on by uncertainty and not emotionally leave. This is really hard. This, though, is the glue that I believe holds principles and virtuous action and religious imperatives together, perhaps sometimes in tension, in order to find the next best step for your patient. The morality that is found in the depth of the patient-ethicist relationship allows experiential training to actually be effective. It turns principalism into clinical prudence. It highlights why autonomy is a poor substitute for respect for persons. It substantiates why it is ethical for a physician to allow a few more days of ineffective medical therapy. It makes room for differences in religious practice within the experience of medicine. And most of all, because we're an Adventist-affiliated healthcare, I believe it is consistent with the teaching and healing ministry of Jesus Christ. So how do we do this? I have adapted this from Johnson, Siegler, and Winslade. They wrote a little book called Clinical Ethics. There's multiple editions out by now. No doubt you may have a copy of it on your shelf. I've adapted it because this is, and I'm actually showing you the process that I personally use when I do a clinical ethics consultation. My mentor, teacher, Dr. Robert Orr, always said that good ethics starts with good facts. No amount of ethics will save terrible medical decision-making. However, good ethics can really help with medical decision-making. So when I get a call, I usually talk with the person who's calling me. I used to, when I first started, I used to say, well, what's the question you want me to answer? And sometimes that seemed to frustrate the caller. So now I listen, I do a lot of open-ended questions. Oh, okay, so this is what's going on. Well, tell me about this. A lot of open-ended questions. And then I start with a chart crawl. And lots of Googling, because how many of you have read medical notes and have not understood a single thing that was written in that paragraph? Yeah, me. All of these abbreviations, what's with the abbreviations? Sometimes you type in an abbreviation and 3 different things, like abbreviation medical, and 3 different things come up with 3 different specialties. So I personally start with a chart crawl, lots of Googling, verifying the medical history with the team, because often the person who's calling you for the ethics consult may not actually know the full medical history of the patient. So verifying with the entire team or verifying with the attending just helps everybody to understand what, or it helps me to understand what what they feel like is the clinical situation. I always search for the Pollster Advanced Directive. So there's the National Pollster Registry. I always search for that. I look at the EMR to see whether there's an advanced directive that's been scanned into the EMR. If there is a post, 9 times out of 10, right, Dr. Moore, it says attempt resuscitation, full treatment. And so, okay, that's somewhat helpful, maybe. The next step, I think, is crucial. And this is where limitations imposed either by the system or by the institution that you work in can, I think, get in the way a little bit. Speaking with the patient and or the family as much as possible. So when I speak with the families about a patient who no longer is able to communicate, or when I just speak with a patient, I start very open-ended. I just met you today, sir. Tell me a little bit about yourself, please. Can you share with me what is it that you love to do? Tell me about how you lived your life before you ended up here in the hospital. And so, Mark, just from our brief conversation this morning, that's very much an approach that I imagine that you would also have with your patients too. Because within these stories, we can often get pretty easily previously stated preferences and wishes, meaning like, if you talk with a family, he told me 20 years ago he wouldn't want X, Y, and Z. We were at the funeral of a family member and we talked about this exact thing, right? That rarely comes up outside of a story. Oh, that reminds me of this trip that we took, yada, yada, yada. So starting open-ended, listening to stories, I think that helps us to not only get at what the patient previously had stated what they wanted, but also if they actually didn't talk with another family member about their end of life wishes, for example, it helps us to understand their lived goals and values. Oh, well, Craig, he was just independent to a fault. He just hated to have people telling him what to do. His first wife left him because, he felt like she was telling him what to do and he yelled at her. And then he just, he storms out of family gatherings, et cetera, et cetera. So this tells you the lived goals and values of this patient, right? And I think you can apply that to medical decision making. It's also helpful to ask about formative experiences. And then usually somewhere in this conversation, the conversation turns to the patient or the family's experience in the hospital. And then that is a gateway to what do they understand of their medical condition? Is it the same as the understanding that the medical team has? Sometimes it's different. After that, what I like to do is then actually formulate what I think is the ethics question. Sometimes it's the same as the discussion that I had with the person who called me. Sometimes it is actually quite different. And I think this is telling in it of itself. If the medical team thinks it is a surrogate decision maker problem and the family thinks it is a truth-telling problem, how likely are they to agree on decisions for medical care going forward? With the medical team, after we come up with the ethics question, I usually get back in touch with the medical team and we discuss what I think the ethical issue is. We go through the burden benefit assessment of the treatments. I asked the team whether there's any ways that they can think of to decrease uncertainty, because uncertainty is a huge factor in many of these cases. I sometimes will say, well, can we look at the guideline from the Renal Physicians Association regarding dialysis, for example? What do you think about this? Oh, yeah, that might be helpful. Okay. You ask the team, is there room for a time-limited trial of therapy? And then, is the patient-clinician team relationship broken? And what can you do to actually augment and foster this relationship? How can you support the patient and the family? And equally as important, and I think, unfortunately, more forgotten, are what are ways that we can support the clinical staff during what is a very difficult time in caring for this patient. Just a brief aside on the assessment of burden and benefit. This gets into discussions about when a physician says, well, I don't think it's medically indicated. Oh, okay. Well, tell me a little bit more about that. Well, it's not medically indicated because it's not going to work. Okay. I do push back, because medically indicated therapy is a therapy that's more beneficial than burdensome and helps the patient towards their goal. Now, how much more beneficial than burdensome that it needs to be and still remains medically indicated, right? This is why we have these conversations in order to figure this out. Not medically indicated therapy. This is therapy that is more burdensome than beneficial, then absolutely, right? So if you have a patient with advanced or severe acute respiratory distress syndrome, ARDS, on maximal ventilator settings. If you talk about the burden and the benefit of CPR, it's going to be highly burdensome, not very beneficial, right? Not medically indicated. So when the physician says this therapy isn't medically indicated, I don't know why the patient or the surrogate is requesting it. Part of this is helping them realize and helping the clinician, the ethics consultant realize, okay, are we talking about like this? Are we talking about like this? Because if it's equivocal burden benefit, then the patient's preference has much more weight in the final decision because they are bearing the burden, the majority of the burden, not all, but they do bear the majority of the burden. Finally, you want to write it up with recommendations that it should address the primary ethical question. I usually also give verbal recommendations to address the relational aspects of the case, but I don't necessarily put that in the formal recommendations. Sometimes it can be I think we do need to be careful in what we write in the official clinical ethics consult, because you don't want your clinical ethics consultation to bias whoever reads it against or for the patient, for example, and all things keeping the patient at the center. So that is, that's our process. However, conflicts definitely emerge, right? And what happens when there are conflicts of interest that emerge? Well, I'd like to first start talking about ways to reduce conflict. And if we are trying to reduce conflict or avoid conflict and conflict still emerges, it was likely inevitable that conflict would emerge. One really important thing is that ethics consultants are not the God Squad. So we don't walk around saying, you morally must do this, or you ethically must do this, right? This is why we have the soft, squishy language of ethically permissible, ethically impermissible. And what we like to say is that we hold your hand so that you can make the right decision. But it's ultimately the clinician's choice for how they should take care of the patient. So one of the things that I try to correct gently is when I see written in a progress note, consulted ethics said to make the patient DNR or something to that effect. I mean, if you read that, it sort of seems like you've got an ethics consultant that says, you should make the patient DNR or you shall make the patient DNR. That's not what we would want to do. We would have preferred, or I would prefer, the recommendation or the synopsis in the note to say, consulted with ethics, discussed burdens and benefits of CPR as a therapy, discussed with the family. This is a therapy that is much more burdensome than beneficial, thus medically not indicated. We will not offer CPR. We have discussed with the family. To me, that is a much nicer way to put it, a much fulsome way of describing probably what happened or what we hope happened. But, that's a lot of words. And so it kind of is much easier just to say consulted ethics DNR. One important thing to making sure that we're not the God Squad is to let your consultees know, or let the service that's consulting you know that you don't have to follow our recommendations. It's okay. We're making these recommendations because based on our training, and if we've really done our homework, meaning that we have invested in that patient-physician relationship or the patient-clinician relationship, we feel like that is the next best thing for the patient. But you don't have to follow the recommendations for the primary team. I mean, I'll give you a quick example for this. One time I was called in extremis by an ICU fellow, and this ICU fellow said, we have a patient who is on 4 pressors. She was a young woman, like 28 or 29, with severe septic shock, history of IV drug abuse, and developed, severe sepsis and then septic shock due to various infections. And so this ICU fellow is saying she's on 4 pressors, and the family is demanding that we do CPR. Can you come help? I'm like, sure. I was in the hospital that day, so I, very quickly walked down. I saw the patient, who it was pretty evident that she was going to die in the next, 1 to 2 hours. I mean, just with her numbers, the way things looked, it looked very, very tenuous. The ICU fellow clearly did not want to perform CPR. So we talked about medically ineffective therapy, what constitutes that, how to take families' wishes into context. And he thought, okay, that all makes sense. Okay. And then we talked with the attending, and the attending said, no, you know what? All they're asking is for 1 round. So we're going to do just, a couple rounds. And the ICU fellow said, but it's not really going to work. And the ICU attending turned to the fellow and turned to me and said, yeah, but it's just 2 minutes. And, that was the end of the discussion. And I thought, okay, that's fine. And so now what is my duty as an ethics consultant? It's to say, that's fine. You don't have to listen to our recommendation. But ICU fellow, let's talk about this. And let's maybe you're too busy to unpack this right now, but when you want to unpack it, give me a call. He didn't call me. But when you're ready to think about this a little bit more, these are ways that you can think about it. And maybe you want to do something different for your own practice. This third point, ways to reduce conflict, it took me a long time to learn. And that is that sometimes your job is just to listen to people vent their frustration. This is really hard for me because when I hear somebody who says, oh, this is what happened, I just like want to call somebody up and say, hey, can you just fix it, right? Or can you look into it? But sometimes your job is just to listen to people vent. Could be the family, it could be the clinician, either. And, I think it's really important to not chart fight, meaning that don't document something in the chart that makes your colleagues not present well or look like they're trying their best, because they're probably trying their best. They just don't know how to communicate that, perhaps. But instead, have an honest conversation with your colleague. This took me a long time to remember or to learn too. Don't do an ethics consult for a patient with whom you have a pre-existing clinical relationship. So, for example, I am I think there's exceptions to this, but generally, right? I'm a pediatric intensivist. And so if I've taken care of a patient in the role of a pediatric intensivist, then I will request one of my colleagues to actually do the ethics consultation. There was one patient where I worked on, I covered on call the unit. And so I introduced myself to the patient's family as I'm the attending physician who's covering call. And then, 3 weeks later, I was requested to do an ethics consult. So if this comes up, when I talked with a surgeon, I said, well, do you really want me to do this ethics consult? Because I covered this patient and, we kind of did some clinical decision-making during that night. And he said, no, I want you to do this clinical ethics consult. I'm like, okay, I'll do it, but I just want everybody to be clear with the potential conflicts of interest here. So the way of mitigating potential conflicts of interest, if you can't avoid them, is to acknowledge them and then try to find ways to adjust to them. At the same time, you have to call a spade, right? If this is not a safe discharge plan, it's not a safe discharge plan. If this patient doesn't have decision-making capacity, and it's going to end up that they're going to be in the hospital for 2 extra days, the patient doesn't have discharge capacity. But be sensitive in the way that you communicate this, because the person who is requesting you to perhaps say something different, they probably have good intentions. So assume the most generous reading of the situation with every person. I'll be honest, I'm still trying to learn this. Call in backup when you have a really difficult case. Again, keep the patient at the center. And then the last two, it's really important to have a process for reviewing clinical ethics consultations. It's important to have a process for reviewing consultations in order to reduce bias. And also, it's actually really helpful to know the practice of your colleagues. And then supporting clinicians through institutional guidelines and policies. If this is an issue that keeps on coming up, let's write an institutional guideline to help with some of the decision-making. There is definitely bias in ethics consultation, and I'm going to end with a couple of slides on bias. As healthcare professionals, we may think that we take an oath to do what is good for the patient, but we are just as affected by biases as everybody else. So this is a systematic review that reviewed 42 articles. In all of the studies, and this last point here, all of the studies that investigated correlations found a significant positive relationship between the level of implicit bias and lower quality of care. I don't think is any different for clinical ethics consultants. So in that vein, this was an excellent article that was published in 2014. These are 6 biases to look for. So when I say biases, what exactly does that mean? Does that mean that we just avoid the conversation? No, I think we double down, acknowledge that we have these biases, and actively search for ways to reduce them. So a bias towards the interests of hospital management. Do we have this bias? Yes. We like to keep our jobs. I like where I practice. A bias towards laws and regulations. Absolutely, because it's an easier answer when you can default to a law or a regulation. But is that law or regulation actually the next best step for your patient? Bias towards ideological or religiously grounded bioethics. Now, this is, I think, difficult, especially for Adventist-affiliated healthcare systems. Yeah. What are our religious beliefs that can actually bias us towards one way or another? Again, having a bias is not bad. We are all biased people. Being aware of our biases, I think, is the important step here. Bias towards inadequate moral perspectives. This gets to our understanding of moral theories. Bias towards individuals' perspectives and interests. So the person who talks the loudest, are they the one who's influencing the conversation the most? And then biases toward the perspectives and interests of health professions. So, they have certain credential after their name. They must be a really smart person, and therefore they must be right. All right, so let's pull it all together with a patient. This is a patient that I had probably the first few years that I started doing clinical ethics consultations. This is a 66-year-old female. She had a history of abdominal aortic aneurysm. This was noted outpatient. She was supposed to follow up with her physician. She never did. She was lost to follow up. And then she's admitted to the hospital for chest pain, and then worked up for acute coronary syndrome or a heart attack. They ruled out the MI, but they noticed that she was persistently anemic. So now they were going to work her up for anemia. So she required repeated blood transfusions, because if you look through her chart, her hemoglobin was 5, they would give her a couple units, her hemoglobin was 7, and then over the next day would drift back to 6 and down to 5. So they were working her up for this. So one afternoon, she complained of having abdominal distension, a lot of pain. And then she had sudden loss of pulses and cardiac activity. So for those in the room who sort of recognize what happens here, they started CPR, they rushed her to the OR. She had a ruptured AAA. So extremely high mortality rate. They did aggressive resuscitation. As luck would have it, for this patient, when CPR was started, the vascular surgeon, excuse me, the vascular surgeon was actually right outside the unit walking down the hall. So was able to get her very quickly into the OR. They got return of spontaneous circulation. Again, aggressive resuscitation. But by the time they came back to the SICU, she had an open abdomen. She had fixed and dilated pupils. She had no urine output. The family talked with her daughter, Sarah, who was, I put 29 here, but she was around this age, who's the patient's surrogate decision maker. And very clearly, Sarah blamed the medical team for the ruptured AAA. Why didn't you catch this sooner? She kept on saying that the vascular surgeon told me that if my mother had only been in the OR an hour before, she would be on her way to getting off the breathing machine. And so in conversations with the team, Sarah continued to request aggressive treatment. The team was painting a very dire picture for her mother. And then Sarah also requested a whole body transplant. And so then this was when the team called me. And in my conversation with the intern, who inevitably is the one who's tasked with calling the ethics consult, I put in a whole body transplant in quotes because that is literally a direct quote. And their question for me is, can you figure out whether Sarah is making appropriate decisions for her mother? We don't think she understands what's going on. She's obviously asking for a whole body transplant, which is, it's nonsensical. And if Sarah can't make decisions because she is not a good surrogate decision maker, who should make decisions for the patient? Because, we can't find anybody else. All right. So we go through the process. By the way, how many of you, if you see patients and do clinical ethics consults, how many of you sort of see familiar shades? Yeah. So good ethics starts with good facts. Now, I've outlined my process, but I'd love to get feedback on what your process entails and what are some differences in the way that you go through this. So I did a pretty thorough chart crawl, all the way back from outpatient when the AAA was noticed. She had been lost to follow-up, what was going on inpatient. And I noticed something really interesting. I noticed that, and this is where I had actually specialized knowledge of the service that she was on prior to her surgery. The service that she was on, the residents had switched to a 12 on, 12 off system. So you had a daytime resident and the nighttime resident. And this was a change from having 24-hour call. So you would see orders being put into the chart by two different people at two different times. And so I was looking back at the blood transfusion history, for example, and I saw, well, on say Monday, she had a blood transfusion order that was placed at 9:00 in the morning. She got transfused, and then a different, and then the CBC comes back, and then you had that same person who placed the blood transfusion order in the morning place another blood transfusion order at 11:00 at night. And then you had the night person actually place a blood transfusion order at like 2:00 in the morning or something like that. So presumably what happened was that you had a very diligent resident who was trying to follow up on labs from their patient, noticing that this patient still needed blood and transfusing even more. And then you had the nighttime resident whose job it was to follow up on the labs, notice that same lab and also write for more blood. And did this mask how rapid of how much blood this patient was losing through this impending ruptured aortic aneurysm? I mean, I don't know. But it becomes clear when you start going through the chart that there were some factors that can actually affect how the attending physician, who then looks at the chart, looks at a hemoglobin, got transfused last night. Oh, maybe that's not so bad. Maybe not realizing that the patient actually got 2 transfusions instead of the 1. Could that have heightened the clinician's intuition as to there's maybe something impending? I don't know. But verifying that medical history with the team was actually pretty interesting, because when I did ask the attending physician about that, that was a surprise, right? It's like, oh, in fact, with abdominal aortic aneurysm, I'm not going to vouch to the medical veracity of this because I don't practice internal medicine, but going back to what that attending told me, that attending said, well, if I had known that she was requiring this much blood, I would have definitely, been more concerned. And also, the more you transfuse a patient with, and the more you increase the blood pressure of a patient with a triple abdominal aneurysm, you could actually increase the risk. Oh, okay. When I spoke with Sarah, clearly she was very set on blaming the hospital for what had happened with her mother. And that was number one for her. And it was, even with all of the, 2 hours of conversation and all of my therapeutic, I'm trying to use all my therapeutic tricks in order to move off of this topic to something else. That was actually the main point of contention for her. So then, based off that information from the medical team and the patient, what do you think the ethics question is? Well, let me ask this. Do you think it is to evaluate Sarah as being an inappropriate surrogate decision maker? Yeah, I didn't actually think that was the case. We talked about the burden and benefit of continuing therapy and escalating therapy. I think the risk of mortality was so high, it was almost certain that she was going to die and die soon. Were there ways for the team to decrease uncertainty? I mean, not really. They were already doing pretty maximal therapy. There was no additional therapy that would be beneficial. Is this a patient clinical team relationship that is broken? Yes, absolutely. Absolutely broken. So what I ended up recommending to the team was you don't have to escalate therapies, right? She's asking for a whole body transplant because she feels desperate that she blames her. Well, not only did she blame the hospital, she blamed herself for bringing her mother to the hospital. And so, talking with the team, the recommendations were really focused towards, okay, you don't have to escalate therapy, but what can you do in order to salvage this relationship? And one thing that the team said, we can't do CPR, because if we do CPR, this is going to just, it's going to rupture. Like, okay, then don't do that. You don't have to do that. But you do have to talk with her and explain that this is why we're not going to do that. But we're also continuing to do X, Y, and Z for your mother. And you are a good daughter. You're advocating for your mother. You brought her to seek medical care. And we are deeply, deeply sorry that your mother is in this situation. And also, we will look at this case and review communication that occurred in this case at whatever process that's been predefined. So I think at the end, did we keep the patient at the center? I think so. What did we focus on most? Was it a medical decision? Can we? Was it the ethics decision? Should we? Or was it the meta-ethical question? The thing that binds the principles together of burden benefit analysis and what a clinician ought to do? I think it was actually the latter. So again, when we talk about the fundamentals, keeping the patient at the center, understanding that the moral heart of clinical ethics and our practice is found in the relationship between the patient, the clinician, and then further situating clinical ethics within a larger institutional and community ethic. I think if we do this, then we will actually be able to provide clinical ethics consultations that have moral integrity and also moral authority. And with that, I'd love to take questions. Oh, what happened? She passed away. She passed away several hours there. I want to remember about 6 or 8 hours later. I do remember, I have this memory of one of the residents texting me that the patient had passed away. They did not perform CPR. I'm sorry? I don't know whether the daughter sued, but I do know that that we spoke with patient relations and asked them to follow up with this. And I do know that this case was put into the process for review there's a committee that reviews cases like this. And so I know that this case was put in that process for review. I did not follow up with the outcome of that review, though. Yeah, but the patient did not receive any more escalation of treatment, did not receive CPR, but also did not, treatment was not withdrawn from her either. She passed away after her blood pressure just sort of dwindled to nothing. Yeah. Yes.
But thinking about our value in helping the cancer.
So great question. And because we're recording this, I'm just going to repeat the question, which is, as a clinical ethics consultant, and please correct me if I'm wrong, as a clinical ethics consultant or in the ethics committee providing deliberation, what can we do at a systems level to improve communications? I think this is where it would be most helpful to have a very close relationship with your quality improvement people. We're really lucky that, Carissa Chianchi is with our patient safety and reliability. This is, I think, a relationship that is natural. It's very cherished because, like you said, one-on-one, sure. But then if an issue is, well, the neurosurgery team is telling the patient something and the primary team, the internal medicine team is telling the patient something else, how do we get these two people to communicate other than by, okay, you come over here, you sit down, let's talk, which sure, you can do that, but it's not very efficient. But having review on a higher level that is often found in quality can actually be really helpful to identify miscommunication. And in the quality and literature, correct me if I'm wrong, Carissa, miscommunication or poor communication is usually like the number one factor in something that happens that now needs to go to, the RCA, the root cause analysis. I mean, it's like miscommunication. Well, I thought they said this, or yeah. Again, it can be really frustrating though to form that alliance with administration, but I think that's where it's at. Yes.
I was just wondering.
Yes, we do. Yeah. Absolutely. A lot of overlap with palliative care. So actually the chair of our ethics committee here at Loma Linda is Gina Moore, who's also the chair of our palliative care division. And so, yes, we do a lot of referrals to the palliative care team. The palliative care team will also refer. I think you should probably get an ethics consult. I agree that we use a lot of the same techniques in order to understand patients' preferences, to get down to the things that give them joy and what are those experiences that actually affect decision making. So yeah, I think there's a lot of overlap. So having a close relationship is, I think, really key with palliative care. Yes.
A little more about it. Say a lot about it. About putting yourself study, like that can be different things.
Yes.
Consult. We'll still give you, like, what does that mean?
Yeah. So great question. And just for the sake of the recording, what does it mean to give your whole self to the consult? So by no means am I advocating that you should burn yourself out by doing this work, although I think there's a very big risk of that. And this is a little plug for our conference. This is actually the close of ours. The close of our conference is going to be the last plenary session where we have Jessica Chen Feng, who's going to come in and actually talk about this. To me, what it means is that you actively engage in this relationship. So it is more than just, oh, I chart checked, I know enough about the patient. It is actively engaging to the best of your ability into understanding and acknowledging and that this is a very real relationship. There's two people in it. You can't be asking from the patient to give you all of this information, and you are not yourself invested in traveling this journey along with the patient. So, I mean, again, it doesn't mean that you have to be on call 24/7 and come in the middle of the night. It doesn't mean you should subjugate your personal life to that. But it does mean that when you're in this work, that you're present and that you are acknowledging the suffering, that you're allowing that suffering or allowing the patient's experience to affect the way that you are deliberating about the decisions that need to be made. Does that make sense?
Yeah, well, and what comes to mind is then you are doing good self-care so that you have the energy to focus to be there when that is needed.
Absolutely. I do. I think that's really key. You know, we talk about wellness. Wellness is a big issue, self-care, wellness. And often I think that's translated to vacation and maybe time off at the pool. But I think and there's nothing wrong with that. But what I think you're getting at is the reflective practice that you need to engage in order to be able to bring your whole self into this. And now I do think that I bring a different self into clinical ethics consults now than I did 10 years ago, based on my experience, based on, my practice, right? So it's, it's engaging. I like that. It's not only engaging with the relationship, but it's also reflecting within yourself to allow you, so you can engage with the patient. Yeah, I love that. Very good. Yes, Mark.
What question how to improve communication basic issues like that? It's one thing in teaching with medical school, but then it comes have ongoing time with people coming and being approved by your medical staff. You have to find that each of them providers. That's sort of time. That's what I'm looking for.
So the question is, how do you have time to engage? Yeah, with your providers. I think that's a huge systems issue, right? And that is where institutional policy and guideline will shape the type of care that patients get simply by physicians or clinicians being able to engage with the ethics resources that are available. Yeah. Hi, Dr. Winslow, how are you? Good to see you.
Fired. That's for exactly. Expectation is.
Yeah. So what is the involvement of the ethics consultant with the committee? It really depends on how your ethics mechanism is set up. So in some hospitals, ethics consultations are done by committee. In some hospitals, ethics consultations are done by a lone consultant. So we at Loma Linda have a lone consultant model. That was, it's Dr. Orr's model who taught us. So we do an ethics consultant. Then that ethics consult is reviewed. It's peer reviewed on a weekly basis. So that's certainly one way to do it. Probably the more common, I would say, is the committee model. And so you may have one person who goes and does a preliminary interview with the family or the team, and then comes back for a fuller discussion as an ethics committee for more discussion. I mean, I certainly think that is also a very appropriate model for a consultation. Yes. Yeah, how do you approach the cultural aspect of a patient? I think that is really found in the conversations that you have with the patient or the families, and understanding or coming from a position of curiosity to try to understand how the advice of their religious leader is going to impact medical decision making, for example, or how medical decisions are made in their culture, how that actually impacts how medical decisions are made in the hospital. Yeah, I do really think that is found in that conversation. So we're going to make this the last question, and then we'll take a short break, and then because we have one more presentation before lunch, and I don't want to hold you too much before lunch. Yes.
That's one of the reasons. that I could have, considered flop.
Yeah, I love that. I could not have said that better. Thank you very much. Appreciate it. All right, thanks, guys. Why don't we just get up, stretch your legs. There's water and coffee in the other room. I'll load up the second presentation and then we'll get started. Thank you. All right, so let's go ahead and mosey on back. So we're going to now start talking about potentially inappropriate treatment. I am hopeful that by the end of this talk, that you will feel like you have a way of approaching this very difficult question. All right, so we'll probably break a little bit later the month for lunch than we intended, but don't worry, you will have the full time frame for lunch. But what we're going to talk about over the next probably 40 minutes together is how we define futile care and the problems that we've had, statements about potentially inappropriate therapy from professional societies, and then we'll end with our take-home messages. So after lunch, we will come back and actually work in groups on our case studies. There are 3 case studies that are included at the end of your packet. If you just want to take a quick look at them now, there are 3 case studies that we will be using in order to try to figure out what is the next best step for our patients. By the way, all of the case studies, they're all taken from real life clinical ethics consultations. All right, but first, this quote is taken from the Corpus Hippocraticum, likely not written by Hippocrates himself, although often it is attributed to Hippocrates, but it's very clear that the author who practiced medicine, who wrote this, was strongly influenced by the guidelines of Hippocrates. So who was Hippocrates? Why was he so influential? I mean, we often call him the father of medicine. He was actually the first to see medicine as a science. So he hypothesized that the brain might be the root cause for epilepsy rather than seizure activity being the result of evil spirits. And so he wrote here, or the author who was influenced by Hippocrates writes, "First, I will define what I conceive medicine to be. In general terms, it is to do away with the sufferings of the sick, to lessen the violence of their diseases, and to refuse to treat those who are overmastered by their diseases, realizing that in such cases, medicine is powerless." So this dates back from the last decades of the 5th century BC to the first half of the 4th century. And even then, they essentially recognized the limits of medicine and its associated technology. And scholars actually thought that it was thought to be in some way, and I'm going to quote here from one of the articles that actually is going to be available in that Google Drive. It was thought in some way for, quote, it to be egoistic for the ancient physician to believe that he could treat patients who were already condemned to die, and any such endeavor was supposed to be hubris against the gods. Well, it sounds simple enough, right? So let's fast forward to where we are here. What is a modern interpretation of what Hippocrates wrote? Well, medical futility occurs when, because of irreversible illness or injury, further medical therapy will not improve the patient's condition. Sounds simple enough. The patient is overmastered by their disease. And this definition, or a version of it, is not only prevalent in medical literature, it's actually codified into law. How many of you guys knew this? So I'm going to go through the laws of 3 different states. So this is from California. California's Health Care Decisions Act. This is the one that we generally quote. This division does not authorize or require a healthcare provider or healthcare institution to provide healthcare contrary to generally accepted healthcare standards applicable to the healthcare provider or healthcare institution. So I personally find this very useful because if I get called for an ethics consult and the question is, well, they're asking me to provide futile care. Do I have to provide futile care? I'm like, no, you don't. The devil's in the details though, and also the definitions, right? Yeah. Okay, so let's look at another state, which is Texas. So Texas, they have this law called the Texas Advanced Decisions Act, TADA. Yeah, TADA, Texas Advanced Decisions Act. And what the Texas law states, it encodes a process that the hospital can go through that will absolve the hospital and physicians of culpability or liability legally if they follow this process. So it lays out a process of how they can remove what they deem to be ineffective medical treatment. So let's go to those red boxes. The patient is responsible for any costs incurred in transferring the patient to the facility. The attending physician and any other physician responsible for the care of the patient and the healthcare facility are not, quote, obligated to provide life-sustaining treatment after the 10th day. So they have a process. You notify the patient of the process. They have 10 days to try to find another facility. The family is required to pay for that transfer. And then after 10 days, there's no obligation to continue to provide that life-sustaining treatment. Well, unless it was that easy, unless ordered to do so under subsection G. Okay, what is subsection G? Subsection G is if there's a reasonable expectation that a physician or healthcare facility that will honor the patient's directive will be found if the time extension is granted. So again, I quote this not because I'm a lawyer, please, I'm not, but the Texas Advanced Directive Act, this process is actually very well documented. Again, it's a process, right? The medical team deems this ineffective therapy. They give notice to the family. The family says, no, I still want this therapy. And then the hospital goes through a process of getting a second opinion. The ethics committee gets involved. And after the review, the committee reviews it. If the therapy is still deemed to be non-beneficial, then the family and the patient, or usually the family, they have 10 days to find another facility to accept care. This period of time can be extended. So the length of time that I found in an article in the Houston Law Review was 14 days. But if a facility is not found, then life-sustaining treatment will be removed. And the law specifically states that the physician and facility, if they proceeded with this above process, they cannot be criminally or civilly liable or subject to review. So remember, under subsection G, which is what we just went through, if we actually continued on reading in the Texas Advanced Directive Act, there is this big carve out, except that artificially administered nutrition and hydration must be provided unless, lots of clauses here, based on reasonable medical judgment, providing artificially administered nutrition and hydration would hasten the patient's death, is medically contraindicated, yada, yada, yada. So the reason why this is in there is because the Texas Advanced Directive Act was passed in 1999, and it caused quite a bit of furor. And I remember there's, lots of talk and articles and presentations at ASBH about this. It's nicknamed TADA, like ta-da or TADA. But despite all this furor, only 2 amendments have been passed to this law. The most recent amendment is this one, which was passed in 2015, which excludes artificial nutrition and hydration from being removed. So this afternoon, we'll actually talk a little bit more about artificial nutrition and hydration. But I just want to keep this at the back of your mind. And I'm just wondering, why would there be an exception to artificial nutrition and hydration? And this be only one of 2 amendments, despite multiple trials of amendments to this law. Only 2 made it. This was one of them. Interesting. Okay, let's go to Idaho. Idaho lists in their law as withdrawal of care right there, we're just going to take points away from them because we never withdraw care. We withdraw support, but we never stop caring. Yeah, so right away, we don't like it. And it says assisted feeding or artificial nutrition and hydration may not be withdrawn or denied if its provision is directed by a patient or their surrogate decision maker, unless, bottom line, such care would be futile care is defined, of course, by another subsection. So let's go to that subsection. This is how they're defining futile care. For a patient with a terminal condition for whom, in reasonable medical judgment, death is imminent within hours or at most a few days, or the denial of which, in reasonable medical judgment, will not result in or hasten the patient's death. So it's hard to square withdrawal of artificial nutrition and hydration and, hastening the patient's death. Like, how do we sort of wrap our minds about it? And this afternoon, we will actually hear more about this. So just an advertisement to come back. But it's interesting to note, is it not, the variability of state laws that address futile care or medical futility. So California says you don't have to do it. Texas says you not only don't have to do it, you can actually take it away if you follow this process. And Idaho says, well, you don't have to provide futile care, but this is the definition of futile care. They have to be imminently dying. And if you take it away, they're not going to die any faster. So does this mean that if a patient's physiologic life is being sustained by a ventilator and death is imminent despite the ventilator, you still actually can't remove the ventilator, because if you remove the ventilator, then they'll die in minutes, versus if you don't remove the ventilator, they're going to die in a few days? All I'm trying to point out is that what started out as a simple definition is now clearly much more complex. And if you are a little bit of a nerd and want to go down a rabbit hole and take a deep dive, I want to, this is not an advertisement. This is just, I do think this is a great website where there's a lot of material on medical futility statutes, thaddeuspope.com. Anyway, yeah, lots of good information that you can pull from there. So let's go back to our definition. There's clearly issues with this, right? And I think the issues are, well, futility, but the word. The second issue is, what does it mean to have irreversible illness or injury? And the third thing, what does it mean that it does not improve the patient's condition? So if we try to shorten them, the second thing, right? Irreversible illness or injury, that's prognostication, right? Not improve the patient's condition, that's outcome. So now we have a problem with prognostication, we have a problem with outcome. And finally, using the word itself, futility, when we say futility, what does that communicate to the family? Well, then let's tackle prognostication. There are a lot of problems with prognostication. I don't know if you know this is true, but every time when they graduate medical students, they just give them a magic 8-ball. I'm just kidding. They actually don't do that, but maybe they should. But one of the biggest problems with prognostication is that it's really difficult to move from pooled outcome data to an individualized prediction, right? So when you say, doc, I have such and such a cancer at such and such a stage, how much more time do I have? I don't want to hear that 90% of patients are going to live X and 10% are X. Well, am I 90%? Am I 10%? The other issue is that physician prognostication can be impacted by personal biases and actually comfort in prognosticating. And the last, even if physicians are accurate, patients may not actually want to believe that information. So how do we know this? This is actually substantiated by quite a bit of evidence. I love this article. So in the world of medical research, probably one of the most rigorous areas of research is oncology. And so oncology, obviously, prognosis, estimation of survival is really crucial. So what the authors did is that they collected data on patients with metastatic brain cancer. And then they asked 3 groups of physicians who commonly take care of these patients to predict individual survival time. And then the survival time was compared to actual survival time. So they asked neurosurgery, radiation oncology, and medical neuro-oncology. They collected 2,700 predictions. 45% of these predictions were off by more than 6 months, 18% by more than 12 months. And interperson analysis showed that predictions differed by as much as 14 months. So they took the same patient, they looked at how wide apart these 3 physicians were at estimating this one patient's survival. The difference was by as much as 14 months. So what can we take away from a study like this? It is exceedingly difficult to make an individual prediction from population-based outcome data. So, will a patient survive for 10 months, but then, we predict a patient survives for 10 months, but only surviving for 3 months? I mean, what is a patient supposed to do also when they hear one number from their neuro-oncologist, another number from the neurosurgeon, and then lastly, another number from the radiation oncologist? It's interesting to note that palliative care physicians at the time of hospice referral were not more accurate. So only 20% of these predictions were within 33% of actual survival. Again, articles are on the Google Drive. And even if the physician was asked to do an up or down assessment of survival on admission to the ICU, their prediction was only moderately accurate. Now, again, I'm not saying that physicians don't know their jobs. It's just that this is really, really, really hard. The second problem is that prognostication can be impacted by personal biases and actual comfort in predicting outcome. And so I'm going to skip down actually to the second bullet point here. When surveyed, right, 65% of patients caring for asymptomatic but terminally ill cancer patients reported that they would discuss prognosis now. In other words, you have a patient, you're caring for an asymptomatic but terminally ill cancer patient with an estimated time to live of 4 to 6 months. Only 65% of patients reported that they would discuss prognosis now versus waiting until the patient actually feels worse and then discussing prognosis. There's a lot of bias that can actually also influence prognostication too. So in this last article, they surveyed critical care physicians at a conference, and they gave them vignettes, and they said, okay, please tell me what you think their morbidity is going to be, their mortality, etc. And so critical care physicians predicted a worse prognosis and recommended limitation of treatment more often for patients who were obese, older, or had a diagnosis of lung cancer. And even again, when physicians are accurate, patients may not want to believe this information. This is a off-cited article from JAMA where patients with cancer tend to be over-optimistic about the probability of long-term survival. So what do we think about prognostication? Well, I mean, it is pretty key to a definition of medical futility, isn't it? What are physicians asked to prognosticate most commonly about? Well, disease progression and reversibility, death, and disability. All 3 things that are really important to figure out whether this treatment is beneficial or potentially inappropriate. How accurate should physician prognostication be, right, before we determine something to be futile? So if we had a disease state where there was 100% accuracy in prognostication, would we feel pretty confident that we could use this prognostication as part of futility? Probably. But what about 80% accurate? 60% accurate? 47% accurate? So now we start to talk about the definitions of medical futility in terms of quantitative and qualitative. So quantitative futility is when the intervention is highly unlikely to achieve its desired effect. But again, this is pooled outcome data, and it's really hard to take pooled outcome data and to make a specific patient prognostication. Problem 2, based on outcomes. So this is qualitative futility. A physiologic effect of the intervention will, will not, this was to say, the physiologic effect of the intervention will not benefit the patient or improve the patient's condition. So this treatment, it's not going to make your life better. You're actually, or you may have worse quality of life, but quality of life is subjective, right? Who should determine quality of life? It's not only subjective, it's heavily influenced by our biases and experience. This is my favorite article to show in terms of how quality of life can differ. How many of you would agree that parents who love their children only want the best for their children, and they're probably in the best position in order to assess their quality of life? Yeah, I hope I'm in a pretty good position to assess the quality of life of my children. So they took children with complex congenital heart disease, status post-surgery, and they surveyed the children and their parents, and they asked them among other things about quality of life and functional scoring. Parents reported significantly lower functional scores compared to their child. Parents also reported significantly lower self-esteem scores than their child. All of this is to say is that predicting a quality of life outcome for another person is really, really difficult. So now we have problems with prognostication, we have problems with outcome. What about the word itself? The word futile is value laden because the interpretation is very subjective. If I say something is futile to you, you may have a very different interpretation of what I am intending to convey. To many patients, it implies hopelessness. It shuts the door on further communication. I also think, especially that it's an exertion of the power imbalance in the patient-physician relationship. So the physician says, if I say to a family, this is futile care, what is the parent supposed to say back? No, it's not, because I don't have a medical degree and I haven't practiced and I'm not board certified. So when can a treatment or therapy be determined to be futile? When physicians are inaccurate and the definition of what constitutes improvement is subjective. So I would posit today that we use or we restrict futility into a definition that is objective as much as possible in a way that invites further discussion and continues to allow for shared medical decision-making. So medical futility exists when the treatment cannot physiologically accomplish its goal. Not going to work. And I think this is a really good definition until we realize that we actually, on a pretty regular basis, when I say we, physicians, actually prescribe physiologically futile treatment often. The most common physiologically futile treatment is when you prescribe antibiotics to treat a viral infection or an infection that you're pretty sure is viral. A treatment that cannot meet the patient's goals is futile, goal-directed futility. But if that treatment meets the patient's goals, it is not futile. Now, the goal may be problematic, right? But allowing that treatment is still allowing the patient to meet its goals. I think it's objective. We can see that. It allows patients and their clinicians to discuss the goals for healthcare. And then it also allows for continued shared decision-making. So whenever somebody says to me, oh, I think this is medically futile treatment, these are the questions that I usually ask them. Well, is the treatment physiologically possible? Does the treatment help meet the patient's goals? If the treatment is physiologically possible and it does help meet the patient's goals, then it's not a futile treatment. it's let's talk about the patient's goals a little bit more. How many of you find this definition satisfying? I mean, it provides some clarity, but I'll be honest with you, I kind of didn't find that real satisfying. There's an aspect of it. I mean, okay, isn't there a little room though? I mean, I understand quantitative, qualitative. Yeah, there's lots of problems with that, but isn't there a little room to define what problematic treatment is? For example, the case that comes up to my mind is, the patient on the ICU unit who's been there for 8 months, who has multi-system organ failure, who requires hemodialysis. And every time she requires hemodialysis, she requires vasopressor support. But because she requires vasopressor support, she's never going to get out of the ICU. Because she can't get out of the ICU. Yada, 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 right? Is this definition of futility helpful? I'm seeing a shaked head. Yeah. Yeah. So there's a couple of guidelines that I want to point you to. Again, this is in the Google Drive that you can access. And this first article is defining futile, which is very similar to what we just went through, and also defining what are potentially inappropriate interventions, problematic interventions, right? Potentially inappropriate interventions. I really believe that at some point, treatments can become ethically problematic. And this is not because treatments are not accomplishing its intended goal, but it becomes ethically problematic because this type of goal is not sustainable, right? At a systems level. So are we moving towards the Texas Advanced Directive Act in which life-sustaining treatment can be discontinued? Or are we moving towards Idaho in which life-sustaining treatment cannot be discontinued? So let's go to this definition. Again, published in 2016. It concerns a functional definition of potentially inappropriate care. So appropriate goals. So first recommendation, appropriate goals of the ICU include treatment that provides a reasonable expectation for survival outside of the acute care setting with sufficient cognitive ability to perceive the benefits of treatment. So survival outside of the acute care setting. So hospitals, ICUs were not built for taking care of patients 8, 10, 12 months in the ICU. Well, then if it's, is the answer to create, and what we've done this, long-term acute care hospitals, is that the solution then? We just create LTACs and then move the patients from the ICUs into the LTACs. That also doesn't feel great. Number 2, ICU intervention should generally be considered inappropriate when there's no reasonable expectation that a patient will improve sufficiently to survive outside of the acute care setting. Okay. And no reasonable expectation that the patient's neurologic condition will improve sufficiently to allow the patient to perceive the benefits of treatment. These are very functional definitions. You can't live outside of the ICU. You can't appreciate the benefits of your treatment due to your neurologic function. And this last one, this definition is not exhaustive because you don't actually have to meet this criteria in order for therapy to be considered potentially inappropriate. Other recommendations to limit the term of futility, which we've talked about. And then number 8, at times it may be appropriate to provide a time-limited ICU intervention, what we call a time-limited trial of therapy, to see whether this therapy truly can meet the patient's goals or if the patient's goals are reasonable. So let's talk a little bit about the time-limited trial of therapy. What is a time-limited trial of therapy? Well, it's limited by time. So it's mutually agreed upon limit of time. We're going to do acute hemodialysis for 3 months. If by 3 months the kidneys do not recover, there is very little chance that kidneys will not recover. If the patient is not a candidate for chronic hemodialysis, hemodialysis will not be continued. Mutually upon goals of therapy. By the end of this time, we will expect to see X, Y, and Z. And then a reassessment at the end of the time-limited trial for further continuation of therapy. I think there's a lot of benefits to the time-limited trial of therapy if structured appropriately. The first thing, it brings the focus back on the patient, right? So instead of using the word futility, which then sets up a confrontation between the family and the physician or the medical team, a time-limited trial of therapy is, let's focus on our loved one, your loved one, my patient in the bed. And by this and such time, if we continue this therapy, we expect to see this to occur. So you have very concrete goals. It brings the focus back on the patient. And I also think it fosters shared medical decision-making. However, it's also heavily dependent on prognostication. So we've talked about the difficulties of prognostication. Let's go back to this example that I gave about acute hemodialysis for 3 months. So, imagine there's a situation and the nephrologist is saying, if by the end of 3 months, her kidneys or his kidneys are not making urine, it's highly unlikely that they will ever make urine. That's a prognostication. So it is still dependent on prognostication, and it requires clear and consistent communication regarding what if the unexpected happens. So what if you're on acute hemodialysis and 2 months in, now you're starting to make urine again? What happens at that point? Well, then you do a reassessment and you do a new time-limited trial of therapy, right? But this requires that the patients and their families trust that you will do that reassessment. It requires them to trust in the process and to trust in the clinical team. And when we're talking about patients who are in the hospital for extended lengths of time, that can be difficult to do. So I like the style of management of plan, do, study, act. You plan, you do it, you see if it works, and then you make a decision accordingly. I also like to stress to patients' families that patients and their families that as their condition changes, so will the time-limited trial of therapy. Fantastic, you got better. Okay, that plan's out the door. Let's do another reassessment and figure out what we can do now. So not only is goal setting important, but also that goals can change over time is really, really important. Not only that goals can, but perhaps they should change over time. And then also, instead of saying, there's nothing more we can do or we're doing everything, we will always do everything beneficial for you or your loved one. If you say everything beneficial, right, it implies that not all treatments are beneficial. It prompts the clinicians and the families to understand what exactly is beneficial. And I think it allows for a discussion of hopes and dreams and a discussion of the limits of medical therapy. Let's go back to Hippocrates. Refuse to treat those who are overmastered by their diseases. I absolutely think we can do this. Reassessment is key. There are limits to medical therapy. We can refuse or decline to treat, but we always care by doing away with the sufferings and lessening the violence of disease. You can do all three things at the same time. How do you do that? This is a guideline that was published by the American Thoracic Society, but also endorsed by a number of other critical care societies. This is a recommended process for how to respond to requests for potentially inappropriate therapy. It emphasizes to not use the word futile unless you are using it in a physiologic sense. And then lastly, have a process in place. So then they recommend an expert skilled in mediation and conflict resolution, verbal and second notice, a second opinion by an expert, an ad hoc institutional committee, and hospital and clinicians should actually assist in transferring or trying to find another hospital who will accept this patient. Let's go through a couple of them just a little bit more in depth. One of them is this ad hoc institutional committee, what are the duties of this ad hoc institutional committee? So those of you who serve on ethics committees, right, this is what the ethics committee would do. What are the duties of the ethics committee? It's to hear from both clinicians and the patient and family, very similar to the ethics consultation process, right? Ensure that the process is being conducted fairly and determining whether, in fact, the requested treatments are inappropriate. I think this last one is really huge. You are actually determining, the medical team thinks is inappropriate, but you are actually determining in this institutional committee whether the treatment is actually inappropriate or not. One way of doing this is to refer back to guidelines, and I put a box around this. I think this is a really good question to ask. Am I certain that the treatment is outside the boundaries of accepted practice? So those of you who are clinicians will think outside the bounds of accepted practice, but you can sort of find that one or two people who are doing that somewhere. Do I have to take that into account? Well, some of the things that we ask ourselves is this treatment broadly unacceptable, or is this a view that's only held by a few clinicians? Again, part of determining whether the requested treatment is inappropriate. Unfortunately, this can happen in a time-pressured situation. So this article does give hints of how to do that if it's a time-pressured situation. You do as much as the process as you can, and you ensure for oversight. I want to go back now to the laws. So we talked about California, Texas, and Idaho. This recommendation number 4, the medical profession should engage in efforts to influence opinion and develop policies and legislation about when life-prolonging technology should not be used. This is really key. To remember, in our last lecture, we talked about ethics consultation sitting within the institution, which then sits within the community at large. So as clinical ethics consultants, as clinicians and practitioners who engage in this work, we also have a duty to engage with the community and to make sure that we are helping to advance the conversation about when life-prolonging technologies should not be used. Lastly, we want to support clinicians through the process, support the families, and it can be actually helpful to have institutional policies to support commonly requested controversial decisions. So on the Google Drive, you'll find a couple of documents that are institution specific. The only request is that you don't widely distribute this, please. But for example, there is a document that was written about CPR and when it's appropriate to withhold CPR in patients. Policies such as, or guidelines such as these can be actually helpful to support our clinicians. Transparency is really key, and then the process of review. I really like this, which is this table here, the 10 most important needs of families with critically ill dying patients. So this is collated from studies identifying the family needs for dying patients. I think it's really relevant to questions. Sorry, that's a typo. I think it's really relevant to questions for potentially inappropriate therapy. So what's really important? To me, the thing that stands out is number 2, to be helpful to the dying person. Why do people request continued aggressive therapy? Is it because they truly don't know that their loved one is dying? No, they know. They know. But also, I think there is also an element that people have a conception of what they need to do in order to be a good family member, a good spouse, a good daughter, a good wife. I need to advocate as much as I can in my conception of advocating for my loved one, because that's what I need to do in order to be a good person. How do we support that? How do we support them in still understanding they can be a good person and make an appropriate, a more appropriate medical decision? So that last one, or the third one from the top, to be assured that their decisions were right. So our take-home messages today: center our communication on the patient in the bed. Use the word beneficial. Don't use futile unless you're using it in a non-physiologic sense. Even the word non-beneficial treatment sounds maybe a little judgy versus potentially inappropriate therapy. Have a process in place and use it. And if you don't have a process in place, let's talk about getting a process in place. Make it as transparent as possible and support each other as much as possible during these very, very difficult cases. And with that, I'm happy to take questions for a few moments, and then we'll break for lunch. And then again, when we come back, we'll start on our case studies. So yes, questions. Yes, Dennis.
Just say a few more words about the ad hoc institutional committee and how that might work or does work in your view.
Yeah. So the ad hoc institutional committee, during this process, it would be, for example, a multidisciplinary committee of people who know that they would be serving in this capacity to come in to do these very specific duties. So because that third duty is determining whether the requested treatment is inappropriate, these are members who have a certain amount of expertise in order to do these deliberations. It could be your standing ethics committee or a subunit if the necessary members are present. Yeah, I do think it could be a subset of your ethics committee to do this, but you'd probably also want to have, for example, a community member. Make sure you include a community member in the deliberation to make sure to offset any hospital-based biases, for example. And so structuring this is not only making sure that there's adequate expertise, but also offsetting any potential bias that can come into the deliberation. And subject matter experts, right, absolutely, about the condition. There's always a question of, where does legal get involved? And, this is why I actually put in this slide, transparency is really important, because when legal is involved, are we now patient-centered or are we risk assessment-centered? I'm not saying that legal shouldn't be involved. I'm just wondering at what level should legal be involved? I think that's very institution dependent. Yes.
About finance. One of the problems that I have encountered in the ICU when it comes to this time of the trial, like intubation, dialysis, and then the straight head and dialysis for this patient that is unfit. How do you suggest we navigate those conversations and thinking about where do you go outside of the ICU, right?
Yeah. Oh man, could you have asked a simpler question? Yeah. Okay, so I would start by saying that I agree that it is very uncomfortable to talk about finances at the bedside, but it's also a reality that I think we should not ignore. It's how we address it in a way that's fair to the patient, that we keep it patient-centered, but also acknowledging that, yes, it is costly for a hospital to provide unfunded care. I do think it is a systems issue because, for example, certain hospitals may get a reimbursement from the federal or state government for actually providing unfunded care. So a hospital administration who gets funding for providing unfunded care shouldn't then also complain about providing unfunded care. Or maybe they can complain, but in a mechanism that encourages transparency. I don't think that transparency is necessarily always there at the bedside, right? it's very difficult to talk about. It's very uncomfortable to think that, oh, this patient may or may not get this treatment because of their insurance status, or they're getting a lesser quality of care because of insurance status. All of to say that these are very real questions that need to be addressed at a systems level. And the hope is that as we integrate clinical ethics into institutional ethics, as we integrate this closer together, that there will be ethicists who are at the table and who are having these discussions with those who are making policy. I saw a question here and then Mark. Yeah, go ahead.
We're talking about prognostication. Difficult with 3 days of therapy. Prognostication was topic of several different discussions, and as they were saying, is the rate of novel treatments are greatly exceeding our data that we have on prognostication. CAR-T, immunotherapy, we're using data basically from steam engines, while today's medical treatment is the bullet joint. And it's nearly impossible to try and take that historical data and apply it to a patient.
Really good point. Yeah. How do we talk about outcome and prognostication with unknown? Yeah. With the unknowns. Yeah. Yeah. Thank you. I was hoping that you would actually have updated information for my slides. Maybe not. Yeah. Mark. Yes. Mm-hmm.
Favorite poll.
It's about the relationship between law and individual. That's the final part. In some cases, the law mandates conduct that is ethically unacceptable. When physicians believe a law violates ethical values or is unjust, they should work to change the law. In exceptional circumstances of unjust law, ethical responsibility should supersede legal duty. Law together.
I'm going to leave this up for a little bit, but well said. Yes. All right. Thank you, everybody. Lunch is on the other side of the room. Let's take an hour and let's be back. Well, maybe 55 minutes. Let's be back at 1:15. And then we will start on our facilitated case discussions. Thank you.